From the time we're kids, we are kind of conditioned to treat certain things as like universal fixes.
Oh, absolutely.
Right, like you scrape your knee, you clean it, you put a bandage on it, you get a sunburn or a weird itchy patch of skin, and you instinctively reach for that bright green bottle of aloe vera gel.
Yep, the classic sunburn cure.
Exactly. It's the familiar fire extinguisher we all just keep in the back of the bathroom cabinet.
Mm.
But what if you are dealing with a highly specific, structurally vulnerable skin condition? And what if that fire extinguisher doesn't just fail to put out the fire, but it actively dissolves the structural integrity of the house while you're spraying it?
Yeah, it is a really sobering realization for a lot of people. I mean, the compulsion to reach for something botanical and soothing, it's incredibly strong.
Totally. Because it's natural, right?
Right. But when we look at the specific pathology of certain chronic conditions, it really challenges, well, everything our culture tells us about gentle, natural skincare.
Welcome to this deep dive. Today, we are focusing on a highly searched, incredibly frustrating question for you. Does aloe vera gel actually soothe a condition called lichen sclerosus?
And this is such an important topic.
It really is. Our mission here is to cut through all the noise of the wellness industry. We've synthesized clinical guidelines from the NHS, the British Association of Dermatologists, and specialized women's health clinics to build an evidence-based roadmap for you.
Because there's a lot of misinformation out there.
So much. We are looking at the actual biological mechanisms to help you manage this chronic condition without accidentally making it significantly worse. But before we even evaluate topical treatments, we have to understand the microscopic environment of the skin we're dealing with.
Right, because it's not just a standard rash.
Exactly. What makes this tissue fundamentally different from, say, a standard patch of eczema?
Well, the foundational difference lies in the immune response.
Yeah.
Lichen sclerosus, or LS, is a chronic inflammatory skin condition. And while it can technically manifest anywhere on the body, it has a very strong predilection for the anogenital region, specifically the vulva and the anus in women, frequently presenting in this very distinct figure-of-8 pattern.
And while men and children can develop it, right, the clinical data highlights a massive prevalence among women over 50,
Yes, exactly.
which correlates heavily with the drop in estrogen during menopause. And that already affects tissue elasticity, right?
Precisely. The visual and structural hallmarks are really unmistakable to a trained eye. The affected skin, it loses its normal pigmentation. It turns white and kind of shiny.
I've heard it described almost like tissue paper.
That's exactly it. At a microscopic level, the dermal layer, so the thick tissue beneath the surface, actually becomes homogenized. The collagen and elastin break down, which gives the surface that crinkled texture, just like wrinkled tissue paper.
Wow.
But the critical baseline to establish here is that LS is an autoimmune-like reaction.
So it's not a hygiene thing?
Not at all.
Yeah.
It is not an infection. It's not a fungus or a hygiene issue. Your body's own T cells are mistakenly identifying the basal layer of your skin as a threat, and they're attacking it.
Which explains the severity of the symptoms. I mean, when the immune system attacks the tissue matrix like that, you get unyielding, deep-seated itchiness.
Usually peaking at night. Yeah.
And extreme structural fragility. The skin just loses its tensile strength, so you end up with tiny, really painful tears called fissures and localized hemorrhaging-like blood blisters from the most minor friction.
That intense fragility introduces a biological mechanism that is absolutely central to managing LS.
Yeah.
It's called the Koebner response.
Okay, the Koebner response.
Yeah. This is a phenomenon where any physical trauma to the skin doesn't just damage that specific spot, it actively recruits the disease.
Let's break down the biology of that response because it fundamentally dictates the entire treatment protocol. Like if I scratch an itch in my arm, it might get red, but it heals.
Right, normal.
But with the Koebner response in LS, applying friction or a chemical irritant causes the epidermal cells, the keratinocytes, to release distress signals, right?
Yes, they release pro-inflammatory cytokines. In a normal healing process, those cytokines would just orchestrate tissue repair. They call in the builders.
Okay.
But in a patient with lichen sclerosus, those chemical signals act like a flare gun for autoreactive T cells. The immune system floods the area, creating this self-fulfilling loop of inflammation. The trauma literally feeds the disease.
Oh, wow.
Yeah, causing the white scarred patches to expand right into the newly damaged tissue.
So if I'm understanding this, we should think of LS skin kind of like a cracked phone screen, like tempered glass.
That's a great analogy.
Applying even the slightest pressure or introducing a caustic substance, it doesn't just sit on the surface. The stress propagates, and the entire matrix spiderwebs and deteriorates further.
That is the exact mechanical reality of the condition. The barrier is already catastrophically compromised. If you introduce friction, or, as we are about to discuss, complex botanical chemicals to LS skin, you are actively accelerating that spiderwebbing effect.
And this brings us directly to the core question of the deep dive. Does aloe vera gel soothe this condition?
Right.
Because intuitively, for someone dealing with a burning, itching, spiderwebbing skin barrier, reaching for a natural plant gel that is roughly 99% water seems like the most logical, gentle intervention possible.
It does. It relies on a very common misconception, though, about the difference between intact, healthy skin and a broken, compromised epidermal barrier.
Okay.
Aloe vera absolutely possesses documented anti-inflammatory and cooling properties for superficial epidermal burns, like a regular sunburn.
Right, the intact skin.
Exactly.
Ow.
However, applying it to lichen sclerosus is an enormous clinical risk. The FDA drug labeling for topical aloe vera is quite clear on this restriction. It explicitly warns against using it for external feminine itching if a vaginal discharge is present, mandating medical supervision for genital application.
And the American Academy of Dermatology highlights a very specific, severe risk of contact dermatitis associated with aloe.
Yes.
To understand why a supposed miracle plant triggers an allergic reaction, we have to look at the phytochemical makeup of the gel itself. Aloe contains a class of phenolic compounds called anthraquinones.
And anthraquinones are fascinating from a botanical perspective.
Yeah.
They're primarily
And if we look at how a cellular irritant behaves on broken skin, the danger becomes super obvious. A gastrointestinal irritant disrupts the mucous membranes and epithelial cells in the gut. Now take that same compound and apply it to a vulva suffering from lichen sclerosus.
It's a recipe for disaster.
The disease has already created fissures. The protective stratum corneum, the outermost layer of dead skin cells that keeps chemicals out, is just completely gone.
You're totally bypassing the body's primary defense system. The genital mucosa is already highly vascularized, meaning it absorbs substances much more rapidly than, say, the skin on your forearm.
Right.
When you apply aloe to those microscopic fissures, you are delivering complex botanical compounds directly into raw capillary beds, exposing them to an already hypervigilant immune system.
So poison ivy is 100% natural and plant-based, but I wouldn't rub it on my arm. Are we saying that putting aloe on broken LS skin is basically inviting an allergic reaction straight into the bloodstream?
Essentially, yes. The botanical compounds act as happens. They bind to the proteins in your exposed tissue, the immune system flags them as foreign antigens, and your mast cells release a massive wave of histamine.
Oh, man.
This is why the clinical reports document patients developing acute eczema, contact urticaria, which are severe hives, and intense burning just from applying aloe to a compromised barrier.
We really have this cultural blind spot where we equate plant-based with biologically compatible.
We do. And a systematic review of topical sensitizers demonstrated that botanical complexes, even those deemed safe for intact skin, behave unpredictably on a disrupted wound bed. Introducing a complex mixture of plant proteins, enzymes, and anthraquinones is a profound, unnecessary risk.
It usually just results in the patient feeling far worse. So, with the natural aloe vera firmly removed from the equation, we have to look at what actually halts the autoimmune attack and repairs that spider-webbed glass. The universal gold standard across medical guidelines from the NHS to specialized dermatology clinics is the utilization of ultra-potent topical steroid ointments, specifically clobetasol propionate.
And I know steroids carry a heavy stigma. Patients are frequently told by well-meaning pharmacists or even general practitioners to use them incredibly sparingly.
To avoid skin thinning, right, or atrophy.
Right, but the pathology of lichen sclerosus completely upends that standard advice.
Because the biological reality is that the unchecked inflammation from the T cells destroys the architecture of the vulva, literally fusing the labia and burying the clitoris infinitely faster and more aggressively than the steroid ever will.
Exactly. Clobetasol is a synthetic glucocorticoid. When applied, it crosses the cell membrane, enters the nucleus, and physically binds to the DNA to switch off the genes responsible for producing those inflammatory cytokines we talked about earlier.
So it stops the attack at a genetic level.
It does. And because of that mechanism, the dosing guidelines are quite aggressive. Patients are instructed to use a fingertip unit.
What exactly is a fingertip unit?
It's a continuous line of ointment squeezed from the tube, running from the last crease of your index finger to the very tip.
Okay, that makes sense.
That specific volume provides the exact concentration gradient needed to saturate the affected tissue. The standard induction phase is daily application for a month to completely suppress the acute immune response.
And then you taper off, right?
Yeah, followed by a gradual tapering down to a maintenance dose, which is usually around twice a week.
But suppressing the immune response is really only half the battle. The steroid stops the fire, but the structural barrier is still dehydrated and super fragile. This is where emollients come in.
Yes, the unsung heroes.
But the clinical guidance strongly dictates avoiding fancy cosmetic lotions in favor of the most boring, chemically inert, fragrance-free ointments available. Things like pure petroleum jelly, a 50-50 mix of white soft paraffin and liquid paraffin, or heavy lipid-based barriers like hydromol.
The preference for inert ointments over aesthetic lotions comes down to formulation chemistry. Lotions and creams are emulsions. They contain high percentages of water.
Okay.
And to keep the water and oil from separating, and to prevent microbial growth in that water, chemists have to add emulsifiers and synthetic preservatives, things like parabens or phenoxyethanol.
And on an intact epidermal barrier, those preservatives just sit harmlessly on the surface. But on the micro tears of LS, well, the emulsifiers lower the surface tension of the product, right?
Right.
Allowing those preservatives to penetrate deep into the raw tissue.
Which fires the exposed nerve endings and causes excruciating stinging.
Ouch.
Ointments, conversely, are purely lipophilic. They are 100% oil and wax, meaning they contain zero water.
Yeah.
So they require absolutely no preservatives or stabilizers. They are totally chemically inert.
And they just sit there and protect.
Exactly. They function entirely as occlusive barriers. They sit on top of the stratum corneum and physically block water from escaping, trapping the body's natural moisture underneath, while shielding the raw nerve endings from external air and friction.
So, to lock in this treatment plan for you, the steroid is essentially the firefighter actively putting out the flames of the immune response, and the bland emollient is the security guard standing at the door to keep irritants out.
Perfect analogy.
And to maximize this dual approach, there is a critical kinetic principle known as the 20-minute rule.
Yeah.
You have to let the firefighter finish their job for 20 minutes before the security guard steps in. You apply the active steroid first, wait exactly 20 minutes, and then apply the inert emollient over it.
The timing is so essential for absorption kinetics. The steroid molecule needs time to navigate through the lipid bilayer of the skin cells.
What happens if you don't wait?
If you apply a heavy occlusive ointment too quickly, you either physically dilute the concentration of the steroid or you create a greasy barrier that traps the active ingredient on the surface. It prevents it from reaching the deeper dermal layers where the inflammation is actually occurring.
Right. So you give the targeted molecular treatment 20 minutes to cross the cellular threshold, and then you seal the environment. But applying that barrier is totally futile if your daily habits are actively dissolving it.
This is where we go back to the Kogan response. Everyday environmental factors act as massive triggers for LS flares.
And one of the most aggressive, completely unavoidable chemical irritants is urine.
Yeah, for an LS patient, standard urination is a primary vector for pain and barrier degradation. Urine is a highly complex metabolic byproduct. It contains urea, uric acid, and various salts, making it highly osmotic and often quite acidic.
And when a highly osmotic fluid washes over tissue that has lost its protective barrier, it rapidly draws water out of the already dehydrated cells, while the acidic pH chemically burns the exposed fissures.
It's incredibly painful.
The clinical mitigation for this is the use of a peri bottle, just a simple plastic squeeze bottle with an angled nozzle.
The physics of the peri bottle are beautifully simple. By squirting warm water over the vulva simultaneously while urinating, you instantaneously dilute the osmolarity and the acidity of the urine before it can chemically interact with the microtears.
So it prevents the stinging entirely.
Yes. And following that, friction has to be minimized. Wiping with dry, abrasive toilet paper triggers the Koebner response.
So no wiping.
Right. Patients must gently pat the area dry with a soft cloth or utilize an emollient on a cotton pad to cleanse the skin without mechanical shearing.
And that mechanical shearing brings us to daily hygiene in the shower. Traditional soap, or even products marketed as pH-balanced sensitive feminine washes, are pretty much catastrophic for lichen sclerosus.
Yes, they are.
The basic chemistry of a soap relies on surfactants. Surfactants have a hydrophilic or water-loving head and a lipophilic or oil-loving tail. They work by micellizing dirt and oil surrounding them so they can be washed away with water.
The problem is that surfactants cannot distinguish between external dirt and the crucial intercellular lipids, the ceramides and cholesterol, that make up your skin's natural barrier.
So washing LS skin with the surfactant completely strips away whatever meager protective oils the tissue has managed to produce.
Exactly. The clinical mandate is to abandon soap entirely for the genital region. You should adopt a method of washing with the emollient ointment itself.
Wait, hold on. Washing with a moisturizer, that sounds completely counterintuitive. How does a heavy, greasy ointment actually get you clean without soap? It sounds like you're just adding a layer of grease over sweat.
I know, it sounds so wrong. But it operates on the chemical principle of dissolves, it's exactly how an oil cleanser works on the face.
Oh, right.
The long hydrocarbon chains in a paraffin ointment readily bind to the sebum, sweat, and dead skin cells on the vulva. When you gently massage the emollient with warm water, the ointment lifts the impurities into suspension.
And then you just rinse it away.
You rinse away the excess, and the impurities go with it. But crucially, because there are no surfactants involved, the skin's underlying lipid matrix remains entirely intact. You achieve cleanliness while depositing a fresh protective layer.
That is amazing. And the friction reduction extends beyond washing into environmental control, specifically clothing.
Yeah.
Synthetic fabrics like polyester, nylon, elastane, they're essentially wearable plastics.
They trap thermal energy and ambient moisture, creating a hyperhumid microclimate that breeds irritation.
And macerates fragile skin. The Koebner response dictates that physical compression and friction must be eliminated. Tight garments, heavy denim seams, and particularly the synthetic adhesives and textured surfaces of daily panty liners create constant low-grade mechanical trauma.
Right. The physiological requirement is 100% natural, breathable fibers.
Like pure cotton or silk.
Yes, which allow for air exchange and minimize shear stress against the tissue. For patients needing to protect their clothing from the heavy ointments, specialized period underwear constructed from bamboo or cotton offers protection without the friction of disposable liners.
Okay, so let's look at the clinical trajectory if a patient is meticulously adhering to this regimen. The aloe is in the trash. The clobetasol is applied with precise kinetics. The barrier is sealed with petroleum jelly. The urine is diluted, and the clothing is frictionless. But they're still experiencing unyielding tissue tightness, severe dyspareunia pain during sex, or persistent fissuring.
It happened.
What happens when the gold standard isn't yielding structural repair?
When the topical steroids successfully suppress the active immune inflammation, but the tissue architecture remains severely scarred or compromised, we move into the realm of biostimulation. We look at advanced adjunct therapies.
Things like fractional laser therapy, radiofrequency, platelet-rich plasma, and polynucleotides. The mechanism of action shifts here, right? Because steroids are immunosuppressive, they stop the destruction. But these adjunct therapies aim to actively wake up the local fibroblasts, the cells responsible for producing collagen and elastin, to rebuild the extracellular matrix.
Exactly. Radiofrequency, for example, delivers tightly controlled thermal energy into the dermis. This microdamage triggers a heat shock response, stimulating new collagen production.
And platelet-rich plasma, or PRP, takes a more biological route. A clinician draws your blood, centrifuges it to isolate the platelets, and injects that plasma directly into the vulval tissue.
The platelets degranulate, releasing a massive payload of growth factors. This signals the body to generate new blood vessels and accelerate tissue regeneration. Polynucleotides operate similarly, utilizing polymerized DNA fragments to enhance cellular hydration.
It's like having a backup generator. You don't rely on it to power your house every day, but it's an option to explore if the main power grid, the steroids, isn't giving you enough juice.
That's a perfect way to look at it. However, the clinical consensus rigorously frames these technologies. The data supporting these therapies for lichen sclerosus is still evolving.
Right.
They show significant promise in small cohorts, but they lack the decades of randomized controlled trials that support clobetasol. They are strictly add-ons, meaning they're used in addition to, never as a replacement for, steroids.
Because you cannot rebuild a house while it is still actively on fire.
Exactly. The steroid extinguishes the immune fire. The PRP or laser attempts to rebuild the framing. But regardless of whether a patient utilizes advanced therapies or relies solely on the standard protocol, the most critical aspect of lifelong management is absolute vigilance.
The daily maintenance and checking for cracks in the foundation is non-negotiable because we are talking about long-term oncological risk here.
Yes. Chronic unchecked inflammation in the skin over decades causes continuous cellular turnover and DNA damage. This creates a statistical pathway for cellular mutation. The clinical data confirms a small risk, generally cited at less than 5%, that lichen sclerosus can progress into squamous cell carcinoma, a type of vulval cancer.
And while the statistical risk is relatively low, the anatomical location makes early detection imperative. Relying solely on an annual gynecological exam is insufficient. The clinical guidelines mandate lifelong, monthly self-examinations with a handheld mirror.
Patients must become intimately familiar with their baseline tissue architecture.
You aren't just tracking the white, shiny patches of the LS itself. You are actively searching for morphological changes that ignore the steroid treatment. A sudden, localized thickening of the skin, a raised nodule, or most critically, an ulceration or raw area that persists for more than 2 or 3 weeks despite the ointment barrier.
Identifying those specific deviations requires immediate dermatological evaluation. Sometimes a biopsy is needed to rule out malignancy. It is about understanding your baseline so intimately that anomalies are caught early. That monthly vigilance is the final, non-negotiable pillar of managing the condition.
Bringing our deep dive full circle to answer the specific question we started with, does aloe vera gel actually soothe lichen sclerosus? The clinical evidence provides a definitive no.
A very hard no.
While aloe might offer botanical cooling to an intact epidermis, applying its complex defense mechanism chemistry to the fragile, immunologically hyperactive tissue of LS bypasses the skin's natural defenses. It drives cellular irritants directly into the vascular bed and risks severe contact dermatitis. When managing an autoimmune structural failure of the skin, chemically inert, thick, deeply boring synthetic barriers like petroleum jelly vastly outperform fragrant botanical complexes every single time.
The clinical priority must always remain singular, halting the internal cellular attack with potent steroids and constructing an impenetrable, frictionless external shield.
It really shifts our entire philosophical approach to skin healing, doesn't it?
It does. I mean, we spend billions of dollars searching for complex, exotic plant extracts to actively interact with our bodies.
Hmm.
But what if the ultimate future of treating autoimmune skin conditions isn't about finding a new biological ingredient at all?
Wow, okay.
What if it's rather about engineering the perfect, completely inert, invisible shield? A barrier that our immune system entirely ignores, isolating the microscopic environment so the tissue can just finally be left alone to rebuild itself.
That is an incredibly powerful thought to end on. The next time you find yourself reaching for that familiar green bottle of aloe to put out a fire, remember that sometimes introducing new elements to the environment only fuels the chain reaction. Sometimes the most medically advanced thing you can do is starve the reaction of oxygen, seal the perimeter, and let the underlying architecture quietly cool down.